I think it's recording now. Okay. Hi, everybody. I'm Guido. Welcome to Pulmonary Journal Club. Today we're going to discuss this article. The name is Dupilumab in Persistent Asthma with Elevated Eosinophil Levels. This is the article. The article was published in the New England Journal of Medicine, and at the same time was presented in the ATS conference in 2013. So this study is a randomized, double-blind, placebo-controlled parallel group phase 2A study. Was conducted in 28 sites in the United States from March 2011 through October 2012. Just a reminder, the FDA classification for randomized trials, we have 4 different phases. So phase 1 is, there are clinical trials that are really small with a small sample size, less than 100 patients. And the idea is to assess the safety and preliminary evidence of the effect of the drug. Sometimes they can classify them in phase 1A, that is in healthy patients or healthy people, and 1B, that is people with the disease that they want to treat. We have the phase 2. There are larger trials, usually between 100 to 200 patients, and the idea is the same, is to assess safety, acceptability, tolerance, and probable effective dose. And also we have the phase 2A trials that the idea is they are trying to assess the safety and the efficacy, but in a selected populations. Like in this trial, they are looking in a specific population, patients with a high eosinophil count and persistent asthma. Phase 2B, also there are well-controlled trials, and they are trying to evaluate just efficacy in patients, but this is not like in phase A that they are trying to use selected populations. This time it's just asthma. We have the phase 3. There are big trials with more than 500 patients. They need these trials to get approval from the FDA for this new drug. And they are assessing efficacy, acceptability, side effects, complications. And the phase 4 trial, they are post-marketing. So once the drug was approved by the FDA, they basically run those trials looking for side effects, efficacy, different type of population with different disease stages. But remember that this is a phase 2A trial, so we are looking for, in a small group, efficacy and safety. So we are going to start with our critical appraisal. So we are going to discuss the patients, the intervention, the comparison group, and the outcome. So patients. They were 18 to 65-year-old patients with persistent, moderate to severe asthma. They have an elevated blood eosinophil count, more than 300 cells per microliter, or an elevated sputum eosinophil level, more than 3%. They also have to have symptoms that were not well controlled with medium dose to high dose inhaled glucocorticoid plus LABA. So usually fluticasone more equal to 50 micrograms and salmeterol 50 micrograms twice a day or equivalents. The intervention. The intervention was Dupilumab. It's a human monoclonal antibody to the alpha subunit of the interleukin-4 receptor. The idea of this medication is that this antibody is going to inhibit the interleukin-4 and interleukin-13 signaling, and both of these interleukin are mediating the Th2 response pathway. And the dose was 300 milligrams, was subcutaneously once a week, and the duration was 12 weeks. So here we have in this graph, just to remember how the Th2 pathway works. So we have allergens, dendritic cells that are going to present these antigens to the T cell, and the T cell is going to activate and differentiate the Th2 pathway, that is the T helper, type 2 helper T cells, that they are going to use different type of interleukins, and they are going to differentiate the cells and create a response activating the mast cells, the B cells, eosinophils, smooth muscle. They are going to activate this inflammatory response. We need to remember that 50% of the patients with asthma, the inflammatory process is related to this pathway. So we are talking about half of the patients with asthma are going to respond with this pathway. So let's talk about the receptor that we are going to try to inhibit. So we have two different type of interleukin-4 receptors. We have the type 1 and the type 2. The type 1 interleukin-4 receptor has two subunits, the gamma C and the interleukin-4 receptor alpha. This receptor, the type 1, you're going to find this receptor in all the lymphocytes. And then we have the type 2 receptor that has two subunits. One is the interleukin-4 alpha and the interleukin-13 alpha. This receptor, you will find this receptor in all the myeloid cells and fibroblasts, microcytes, monocytes. So the idea of this antibody is to block this receptor, the alpha subunit. And blocking the alpha subunit, you're blocking the complete, the full receptor, so there's no going to be any of the signaling that is going to activate different cytokines that are going to create the inflammatory response, and they are going to differentiate the cells. So here we have another picture, and so the idea is that the antibody is going to attach to the alpha subunit. And once it's attached to the alpha subunit, interleukin-4 and interleukin-13 are not going to work. Remember that the type 2 receptor also has a subunit that works and is activated by interleukin-13. So just blocking the interleukin-4 alpha subunit, we are basically annulating the complete receptor. So it's not going to work for interleukin-13 either. Here we have the flow sheet of the intervention. So you can see that during the screening period, we have patients with, that are taking albuterol as needed, plus fluticasone with salmeterol. Different doses. Some of them are taking 250, the other patients are taking 500. So once they were randomized, they were divided in two arms. Half of them received the Dupilumab, 300 milligrams weekly, and the other arm received placebo. Same thing, weekly, and was also an injection. They have like 4 weeks, there's a phase of 4 weeks that they were receiving all the medications, the LABA, the inhaled glucocorticoid, plus the drug versus placebo, and they were using albuterol as needed. After week 4, they stopped the LABA, so they were only getting or the drug versus placebo plus the inhaled glucocorticoid, but they were trying to tapering down. So by the end of the week 9, basically they were only taking a monotherapy. They were using or placebo or Dupilumab. They were not using any other medication. Well, and albuterol as needed. So from week 9 to 12, there was a monotherapy phase, and after week 12, they resumed their regular medications, and the drug was stopped.
So,
Yes.
Part of me wonders how they got people to consent for this study, because you have to tell them, okay, so you're already not well controlled, and then we're going to step down your therapy, so and there's about 50% chance you're going to be on no asthma medication. And I want to see what happens to you. Like, I wonder how that sort of consent and how that got through
An ethical,
IRBs.
yeah.
I don't know if you have any thoughts on that, Mike, or if you were going to touch on that later, it's fine. But I just, yeah, it just seems like an interesting way to do it. So
Basically, yeah, basically they stop their
they
lava.
took them down, but,
Yeah.
yeah.
So
And the time that they were on nothing was just was a 4-week period
yes,
of time. Okay, all right.
and we'll see with the results how this is going to affect the placebo group. Our comparison was placebo. It was the same. It came the same, like in a syringe, and the patients was injected by the personnel in the site, and they injected during every week during their regular visit. They were blinded, and the duration was also 12 weeks. So let's talk about the outcome. So the primary outcome was the occurrence of an asthma exacerbation. They define the authors define asthma exacerbation using these criteria. One was a reduction of more than 30% in the morning peak respiratory force from baseline in 2 consecutive days. 6 additional inhalations of albuterol in a 24-hour period related in 2 consecutive days. Exacerbation requiring a systemic glucocorticoids, an increase in inhaled glucocorticoids to 4 times a day, admission to the hospital, or if the physician that was taking care of the patient considered this episode an asthma exacerbation, that was also considered an asthma exacerbation. Our secondary outcomes, time to an asthma exacerbation, change from baseline at each visit and at week 12 in the FEV1, morning and evening change in the PEF, ACQ score that is in the Asthma Control Questionnaire that I will show you later, morning and evening asthma symptoms, nocturnal awakenings, and a number of albuterol inhalations per day. I must say that these are a secondary outcomes, so remember that the sample size for this study was not calculated for these outcomes, so we should focus on the primary outcome. This is the ACQ score. There's 5 questions. The first question is asking you how often were you woken by the asthma symptoms during the night. The second question is how bad your symptoms are in the morning. Third question is how limited your activities are related to because of your asthma. The fourth question was how much shortness of breath do you have, and the fifth question was how much wheezy do you have, and you have on a scale from 0 to 6, and basically they, depending on each answer, they record the score, and they were using the same questionnaire during every visit, and they were looking and they were reviewing the changes. So let's start with our questions from our critical appraisal guideline. So was the assignment of the patients to treatment randomized? So the answer is yes. So this is a randomized trial. Basically, they assigned it in a 1-to-1 ratio by a centralized system to receive Dupilumab or placebo for 12 weeks. Were the groups similar at the start of the trial? So we have this table that show us the baseline demographic and clinical characteristics of the participants, and you will see that both groups are similar. The age, sex, race, BMI, duration of asthma, number of asthma exacerbations in the last 2 years, combination of therapy. Both groups were similar, except for the blood eosinophil count that was higher in the Dupilumab group. That's the only one that is statistically significant with a p-value of 0.04. We have other characteristics like FEV1, asthma scores in the questionnaire, and the nitric oxide exhale, and other biomarkers that are part of the secondary outcomes. But both arms were similar. Aside from the allocation treatment, were groups treated equally? The answer is yes. Both teams were treated equally. The personnel and the clinic office were blinded, so they didn't know exactly which patient was getting what, so they were treated the same. Were all the patients who entered to the trial accounted for? So the answer is yes. So this study was analyzed by intention to treat. So every patient that was randomized to each arm was analyzing that arm, even though if the patient had a side effect or had a drop off of the study, he was analyzing in the arm that he was randomized. So there were 491 patients that were assessed. 387 were excluded for different reasons: low eosinophil count, inadequate ACQ-5 score. They don't meet the inclusion or exclusion criteria, and there are different reasons. 104 patients underwent randomization, and 52 were assigned to the placebo, and 52 were assigned to the Dupilumab arm. We can see here that there were 33% of withdrew in the group, in the placebo group, versus 13% in the Dupilumab group. And this is important because the sample size calculation was based on a drop-off of 10%. So this is more than the way it is expected for this trial. But at the end, 35 patients complete the study in the placebo group, 45 patients complete the study in the Dupilumab group. Were measures objective, or were the patients and the clinicians kept blind to which treatment was being received? As I mentioned before, this is a double-blind placebo-controlled trial, so they were blinded. They were assigned in a 1-to-1 ratio by a centralized system. So basically in the clinical side, they have different boxes with syringe, and that box has a number. So the centralized system, once the patient is in the clinic, is going to give you a number, and you will use that box with that number, and you don't know if that is a placebo or is a Dupilumab. And the injection was administered by the investigators or the site personnel during that visit. What were the results? So the next question is, how large was the treatment effect? So we have here, remember our primary outcome was the occurrence of an asthma exacerbation, and during the 12-week period. So in Dupilumab, they have only 3 episodes of asthma exacerbation versus 23 episodes of asthma exacerbation in the placebo group. They analyze this data with logistic regression, so they calculate an odds ratio that was 0.08. That means that Dupilumab is going to protect you against asthma exacerbation, so it's showing protection in the Dupilumab arm, and this was significant. Here we have what type of exacerbation, or how can they define an exacerbation. So most of them were because they were having a reduction in the morning peak expiratory force from baseline. Some of them they need to use 6 additional inhalations of albuterol, the use of systemic glucocorticoids, and increasing the dose of inhaled glucocorticoids. Usually when we review clinical trials, we expect other type of measures. We expect relative risk reduction, or number need to treat. This time they use odds ratio because they were using a different type of analysis. They use logistic regression analysis. So just to give you a little bit of insight about what is logistic regression. So logistic regression is a model that they use when you have a dependent variable, so in this case is asthma exacerbation, and you have an independent variable that in this case is the Dupilumab. So when you only have these two variables, you can calculate the association using a relative risk. But in this case, we have other variables that can interfere with the result, meaning we have the use of LABA, the use of fluticasone. Sometimes they were using just a monotherapy, and for a period of time they were using the 3 drugs. So we have different variables that can affect our dependent variable, that is the asthma exacerbation. And each of those variables can generate an odds ratio. So what this model does is basically it's going to calculate an odds ratio for each variable, and it's going to take in consideration the other odds ratio. So you're going to have a good analysis and an odds ratio that is going to associate each independent variable with this dependent variable. So we are going to have an accurate measure of this association. But because we're here in the Pulmonary Journal Club, I decided to calculate the relative risk and with the data that was provided in the article. This data was not provided in the article, but I calculated to have the numbers that we used to use. So this is a 2x2 table that is showing the exacerbation and each arm with Dupilumab and placebo. So I calculate the risk of exacerbation, or the incidence of exacerbation in the Dupilumab arm was 0.06 or 6%, and the placebo group was 44%. With those two numbers, I calculate the relative risk, that is basically the ratio between the percentage of incidence in the Dupilumab group and over the control group. So it's 0.14. Remember that the odds ratio that is similar was 0.08. So anyway, it's showing us that the Dupilumab is going to protect you against asthma exacerbation. We have the absolute risk reduction, that is also another type of measure that I calculate based on the risk of exacerbation in each arm, and is 38%. So that means that the absolute reduction in episode of asthma exacerbation in the Dupilumab arm was 38%. Then we have the relative risk reduction, that is 1 minus the relative risk was 0.86, so 86%. That means that there's like a decrease in 86% of episodes of asthma exacerbation in the Dupilumab group in comparison with the placebo. And the number need to treat is 2.63. That means that you need to treat 3 patients to prevent an episode of asthma exacerbation. In this graph, we have the same number that I gave it to you earlier, the relative risk reduction, but this was given by the article, and it was 87%. The one that I calculated was 86, pretty similar, with a p-value of 0.001. So there's a big difference between the Dupilumab versus placebo. We have our secondary outcomes for each arm. One of them was the time to asthma exacerbation, and that was calculated by a Kaplan-Meier curve. Using a hazard ratio that was 0.1. That means that Dupilumab will prolong the time of an asthma exacerbation in the patients that were using it compared to placebo. The change in the FEV1 from baseline to 12 weeks was also significant. In the Dupilumab group, the FEV1 was similar, but the difference in the placebo group was the volume was decreasing more than 200 mL. The change in the morning peak expiratory force was also significant. It wasn't significant during the evening. There was no significance there. The change in the ACQ-5 score was also significant. The change in the morning asthma symptoms was significant, as the change in the evening symptoms. The nocturnal awakenings was not significant, pretty much the same in both groups. But remember that we didn't calculate sample size to get like a significant results on this type of secondary outcome. So I think we need to focus more in the primary outcome. Here we have the Kaplan-Meier curve. So we see that there were 3 episodes of asthma exacerbation in the Dupilumab group, and so these are 3 episodes. And you can see the other 28 episodes of asthma exacerbation in the placebo group. How was going on? And what I like about this graph is that it's showing us when the patients were taking the Dupilumab or placebo plus the LAVA and fluticasone until week 4. Both were similar. And then when they stopped the LAVA and they were tapering down the dose of the inhaled glucocorticoid, the episode of asthma exacerbation in the placebo group was going sky high.
Just one question. Is if the patient has more than 1 episode, that counting 2 episodes, or each individual is 1 episode?
One episode is 1 individual, because yeah, in this hazard ratio, once when you have 1 exacerbation, they are not going to keep your numbers in. So you can see how the numbers are dropping out because you have an exacerbation. So you don't yeah. Here in this graph we have the FEV1, and one side we have the percentage, and the other one the volumes. We can see that there was not significant difference when we talk about the volumes in the Dupilumab versus placebo, because the confidence interval were touching each other, so there's no significant difference. But when we see the percentage, there's a significant difference between both groups. We can see how the volumes are decreasing in the placebo group. Nocturnal awakenings, we talked about this, that there was no significance between both groups, and as you can see, there's the confidence intervals are touching each other, so there's nothing there. The fraction exhalation of nitric oxide. Here, this is one of the biomarkers that we are using for evaluate Dupilumab and blocking the Th2 pathway. So we can see how in the placebo group, actually the nitric oxide is going up, while in the Dupilumab group is basically going down and stable, even though we stop the LAVA and we are tapering down the dose of the inhaled glucocorticoid. This is still in the low side. The CHARC is it's a thymus activator cytokines that are produced in the thymus, and the idea of measuring this is they are also really related to the Th2 response, and we are trying to block that pathway. So this is another biomarker that we are using, and as you can see how Dupilumab is basically decreasing the levels of the cytokines compared to placebo. Eotaxin 3 is other type of cytokine that is produced by eosinophils, and the idea of blocking the interleukin 13 and interleukin 4 was to decrease this, the mean of the eotaxin, and actually Dupilumab did it, and the placebo group is not. IgE. There was no significant difference between both groups, because as you can see, the confidence interval is really big in the placebo group and it's touching the Dupilumab group. That's because we didn't calculate the sample size for this, so that's why it's like this. The next question in our critical appraisal is, how precise was the estimate of the treatment effect? And I think we talked about that. We calculate the OR, and the confidence interval is between 0.02 to 0.28, so it doesn't cross the unit, and the p-value is 0.001. The next question is, will these results will help me in caring for my patients? So remember that this is a phase 2 trial, so it's not FDA approved. There are more data that we need to analyze. And the next question is, what about the adverse effects? So we have adverse events here that were similar amount, 40 in the placebo group versus 42 in the Dupilumab group. We have some serious adverse events that there were 3 in the placebo group, basically unrelated to the drug. I think one was a pneumothorax, the other one was a fracture and a pneumonia, and the Dupilumab group was also a pneumonia.
They mentioned everything that happened.
And then you can see that there was no death, and we have injection site reactions, upper respiratory infections, headache, nausea. So it's basically what the patients had during that 12-week period. So most of them you will think that they are unrelated, like arthropod bite or muscle spasms.
They were saying that there was a chance that the like rhinitis stuff would get
Yes.
worse, but by the scores it looked like it didn't. It's not 22. It didn't get worse, and then
Yes.
by this it sounds like.
That's correct. They use another score to evaluate the sinusitis and the rhinitis, but it was not significant.
So which of those ones are significant? Like these right?
None of them.
None of them. All right.
Any comments, any questions? Go ahead, say.
I didn't understand. I mean, why was the comparison group patients who were on no medications at all? Why didn't they compare, for example, those who are on maximum therapy, or why wasn't it an add-on therapy versus placebo? I mean,
So
the theory is just.
So just because this is a phase 2 trial, they are trying to look for efficacy, and they are trying to evaluate during different stages. So they think that in the first 4 weeks, they kind of evaluate the drug with LAVA and fluticasone as a co-treatment. They have a period of time when they were only using the Dupilumab with fluticasone, and there was a period of time that they were evaluating Dupilumab just as a monotherapy. Remember that this is just like a preliminary trial, was only 12 weeks, and they are trying to get all the information as much as they can from the efficacy. And I think I understand your point, because you will think that
Take a look at the results from randomization to week 4 and on, for example, or for those who are on something.
that's why they use the logistic regression to analyze and put all these variables in the model and get a result. Yeah, it's hard to say. Also, when I was reading the article, it was like, obviously the placebo group they are going to have more symptoms at the end of the study, because basically they took all the
trying to maximize the number of people on the primary outcome, which is supposed to happen more on people without any treatment at all. If you put them both on good treatments and you add the Dupilumab on that kind of small number, you're not going to get any difference unless you have a trial like this that actually tells you that it can be useful, so then you go to the next step and then you put a patient on both treatments and then see what happens.
And with this, how it is, it argues that with this drug, you could withdraw the therapy. They might even be going for primary indication too, but I agree with Eric. I think it's to show the largest difference possible. So kind of going along with that, I didn't get a chance to look at the addendum stuff, but did they, or the appendix, did they make sure that people were getting other therapies like Singular, and I think this is before people were using Spiriva much more, but those were not on there?
No,
Okay.
no.
They
And
wouldn't
if
be on them?
what happened is that they found lack of efficacy, and the patient was having a lot of symptoms.
Right.
They basically discontinued the patient from the trial. So that's why we have like this amount of number.
For baseline meds, were they allowed to be on like a leukotriene receptor antagonist?
No,
Or a LAMA?
no,
They're not allowed to?
no,
Okay,
no.
all right.
That was an inclusion criteria, and I don't know where I put that here. So
So it's sort of styled in the same way that there's that really old study looking at, it's like why we don't use long-acting beta agonists alone in asthma patients. It's also New England Journal of Medicine. A little bit different, but it looks at sort of if you give Dupilumab, can you safely withdraw and inhale corticosteroids? And it showed that they have much more events. You know, we can do that, and that's why we that way. But I don't know if they're doing it mainly just for that big difference. I don't know if they have a different opinion like that, just to find the biggest difference possible, or if they're sort of the next step for them is going to be arguing as like a primary therapy for these patients.
When Sally Wenzel presented the paper, I guess her response to some of the questions was, yes, we showed them the drug works and we can have exacerbations as you can, but ethically doing so in a lot of severe issues. So why do you like draw therapy from an individual that's arguably uncontrolled? I imagine there's something that's smarter than I am in institutional where it said, okay.
I wonder if that's what I was asking, did they do like a central? Because I wouldn't get a lot of it. I wonder if they did like a central one because then they wouldn't have the same. Because I can see institutions having
different IRBs.
Like some having an issue. I mean, she's a very smart woman, has done a ton of smart physician clinician researcher, and has done a ton of asthma work. And I guess maybe they said their argument is that they were following them so closely, or yeah.
Any other questions or comments?
So what do you do with this information? Let's say it gets FDA approved like next week. Are you giving it?
I think we need more information about side effects, more information about efficacy, but to me it looks like a good drug, and it's once a week. We need more information, definitely, but I think it's something.
The way they did it is patients who are already on therapy, not well controlled. So it may help you with as you're tapering, again, you watch them because you're tapering steroids. The other thing is that they taper that steroid much quicker than you normally would. Or especially, I mean, again, you wouldn't be tapering it for the other issue that I thought that was like, maybe 10 years ago, it was all about IL-13, and this sort of explained, like, we went through the mechanisms why that alone probably wouldn't be.
Speeder.
There was but the IgE is not the same.
But they use more the eosinophil count in the blood. So let me show you the. So basically, the type 2 receptor, you need both the interleukin 4 and the interleukin 13. So if you only block the interleukin 13 part, you still have the type 1 interleukin 4 receptor that is going to continue the signaling. So you need to block both receptors. And I think that's why they choose the alpha subunit of the interleukin 4, because with that, you're blocking these two different type of receptors instead of blocking just the 13 one, because the other one will start working. I think that's how they define to use the interleukin 4 receptor.
So I guess this is not an experimental drug, right? This is being used in some other conditions.
No, it's a new drug. There are also trials using this for atopic dermatitis and rhinitis.
So this is not experimental.
Yes, yes, they are using this for basically all the type of atopic diseases.
The initial turnaround for the FDA, I know for the IPF drugs are looking at them because it's much quicker, and same for chemotherapeutic agents, they look at them much quicker because, again, you can argue there's no treatment, so they can fast track in terms of moving up that timeline. So I'm not sure, because we haven't really heard much about this since then, unless I'm missing something, but it's been a year, so I don't know.
They're
just, well, they also may have to conduct their phase 3, right? So it's probably in the midst of that.
They were doing the phase 3 etc.
Okay, so something will come out soon then.
Yeah. Thank you. Eric, do I stop the?